Yeah, I can see only about 20 people here. Are we going to see any more people?
Shall we
Or
wait for another 2 minutes, sir?
yeah, okay.
Thank you, sir. Sure, sir.
Yeah, so basically, the CLD is on shortness of breath. So we will try to make it as a more interactive kind of a session. Since we don't have many students also, you all can also involve in the kind of discussion. So let's start. So basically, we first start with the case history. So this is a 48-year-old school teacher who is a mother of 2 children from Pamankada, and she finds it difficult to talk to the class after climbing 2 flights of stairs at school. So she finds breathless after climbing 2 flights of stairs, and then after that she takes a while to start talking. So this is her presenting complaint, and she's tired and short of breath for the last 2 to 3 months, which is getting worse. And she has initially attributed to this to age, and there had been a recent weight gain. And also she had noticed that her feet is getting swollen towards the end of the day, and her slippers are getting or feeling tight. So this is the presenting problem. So so essentially she complains of a difficulty in breathing, especially after exertion. So can you tell me what are the things, what else you would want to know about this patient before we move forward? So you can talk. It doesn't matter. You can tell anything.
So whether there was a heart disease history previously?
Okay. So whether she has had any heart problems, because you are thinking of what?
Heart failure?
Yes. Okay. Any other thoughts? This is because
urine output of the patient, because it might be related to a renal problem also.
Okay, so how does renal problems cause shortness of breath?
Fluid overload due to acute kidney injury can lead to shortness.
Okay, so any problem with renal failure, okay, leading to acute or chronic renal impairment can lead to fluid retention, causing shortness of breath. So that's correct. Any other thoughts? Anybody else? Okay, so before moving on, we need to get a basic idea as to what shortness of breath or dyspnea means. I'm sure you would have had this lectures about dyspnea physiological basis when you are doing your basic sciences module, but I just refresh those things. So basically, dyspnea means it generally means a subjective perception of a discomfort associated with breathing. So basically, it's a feeling. You feel there's a feeling that you have some discomfort associated with breathing. So it's a very vague term, but it's generally what it means. So dyspnea is generated due to four main mechanisms. Obviously, there are different ways of classifying the mechanisms, but this is one way of classifying it. So either these mechanisms can operate in isolation or in combination in order to bring about dyspnea. So these are the broad categories. So obviously, respiratory system problems in the respiratory system is number one. So what is meant by a respiratory system problem is you need to get a neuromechanical dissociation involving the respiratory system. So what do you mean by a neuromechanical dissociation? So generally, you know that there is a there is a central control of respiration. So you have the brain stem, there's a respiratory center, and also there's a cortical center. So basically, these centers, there's a efferent pathway to the respiratory system, especially to the chest wall, to the airways, in order to initiate breathing. And this breathing effort leads to breathing. So the resulting air entry should be equivalent to the effort that you put in. So if you make an effort corresponding to that particular effort, a corresponding amount of air is taken into the lungs, and this is sensed by the respiratory receptors in the airways, and then it's transmitted to the brain. So that is the afferent system. So the brain will perceive whether your effort leads to a corresponding amount of air coming into the respiratory system. So it has to be matching. So if that match is there is no problem. But if there's a mismatch, for example, if you put in a lot of effort, but the respiratory system does not take that much of air in amounts corresponding to that effort, then there's a mismatch. So this mismatch is perceived by the brain, and that's when you get this feeling of shortness of breath or dyspnea. So you need to understand this concept. So this is called the neuromechanical dissociation. And this is the primary stimulus for the generation of dyspnea. So you make an respiratory effort, but in return, you don't get this amount of air that is expected into the respiratory system. So because of this inadequacy, the brain senses this, and this leads to a sensation of dyspnea. So generally, this is, if in addition to that, if there is so this is basically a mechanical process, in the sense like, the sensations are basically some sort of a stretch receptors or some airflow detection receptors that will sense this imbalance and will be, will convey that to the brain. But in addition to that, if you have a ventilatory stimulus, for example, these ventilatory stimuli, if there is a hypoxia, that means reduced oxygen partial pressure in the blood, or increased carbon dioxide partial pressure, or there is acidosis, things like that. If that is also there in addition, then the stimulus is more potent, so that you feel you get the dyspnea more profoundly. But the primary thing is actually this imbalance between the force of breathing versus airflow. So that is the primary reason. So many respiratory diseases give rise to this imbalance, and that is why you get shortness of breath in respiratory problems. Then in addition, the second group is the cardiovascular pressure. So I will just move on to the next slide so it will make it easier for you to understand. So this is the shortness of breath. It's activated. It's caused by secondary, it's basically caused by the sensation in the amygdala, in the brain. And so this is called a secondary amygdala activation due to a problem in the respiratory system. So what are the respiratory problems which can give rise to these issues? Whether if there's an airway problem, if there's a lung parenchymal problem associated with compliance issue, or if there's an increased dead space. So any of the diseases in the lungs causing any of these problems will give rise to neuromechanical dissociation, giving rise to a sensation of dyspnea. And this is kind of potentiated by the presence of either hypoxia or hypercapnia or acidosis. So this is the part, the physiological mechanism of the dyspnea resulting from a respiratory problem. Then not only respiratory problems will give rise to dyspnea, there are cardiovascular problems also will give rise to dyspnea. So for example, if there's increased pressures in the cardiovascular system, this could happen in the cardiac chambers or in the cardiac, major vessels like aorta, or if there is it can happen in the pulmonary vessels. So these cardiovascular, in the cardiovascular system, there are receptors. These are mainly baroreceptors. They are related to stretch. So if there's distension of the heart or main vessels or the pulmonary vessels, that is also one of the stimulus. That is a stimulus to cause dyspnea. So we have this notion that cardiovascular disease usually result in shortness of breath or dyspnea due to pulmonary congestion or pulmonary edema. That is not absolutely correct. That will also happen in that situation. For example, if you have left ventricular failure, there is accumulation of fluid in the lungs. So that also can give rise to reduced lung compliance, giving rise to shortness of breath. So that can also happen. But even in the absence of pulmonary edema or pulmonary congestion, just the cardiac disease per se can give rise to shortness of breath. So this is the mechanism you get in some people with heart failure who doesn't have pulmonary edema, but they can have shortness of breath, then they exert. And this is caused by these mechanisms. So these are the two main groups of causes which can give rise to dyspnea. In addition, there are other factors like, for example, acidosis. So acidosis can give rise to direct stimulation of the central nervous system, gives rise to dyspnea. So these are the three main groups, but in addition, there can be primary direct problems in the central nervous system, which can give rise to direct activation of the respiratory center, causing dyspnea, such as in anxiety, depression, post-traumatic stress disorder, or panic disorder. So these are the big groups, main mechanisms of dyspnea. So you need to understand these broad physiological mechanisms in order to tackle the patient with dyspnea. Now, having done that, let's move on to this complicated slide. It's a bit, so I'll just get it up like this. Is easier that way. So, so these are again this is another slide in order to try for you to understand the various broad categories of causes giving rise to dyspnea. So you have, as I told you, pulmonary causes can give rise to dyspnea. So you have problems in the airways, parenchyma, pleura, or the thoracic cage giving rise to dyspnea. I'm not going to give you individual diseases, but just a broad groups. Then you have the cardiac causes. I told you about that. So cardiac causes, I told you that, problems in the heart, like, heart failure can give rise to, for example, heart failure can give rise to pulmonary edema and cause dyspnea, or it can give rise to baroreceptor activation because of stretching of the cardiac chambers, and that also can give rise to dyspnea. In addition, valvular disease also can give rise to stretching of the heart as well as pulmonary edema, giving rise to dyspnea. So these are various mechanisms of dyspnea. Then in addition to that, ischemic heart disease also can give rise to dyspnea. This is called angina. So for example, if there is some blockage or narrowing of the cardiac vessels, when there is inadequate oxygenation to the cardiac muscles, so then this is sensed as a, then the body, the respiratory center tries to increase the respiratory rate in order to increase the oxygenation, and you get a feeling of dyspnea. This is called a, so shortness of breath can be just some people can be the only manifestation of angina. So this is called angina equivalent. So especially in elderly people, sometimes they come with shortness of breath on exertion, and that is actually an angina as a result of angina. So you need to remember these cardiac factors which can give rise to shortness of breath. In addition to that, you have acidosis, and you have psychological causes, and somebody mentioned about renal causes. So renal causes again can give rise to shortness of breath or dyspnea due to different mechanisms. So kidney problems can cause hypertension, giving rise to heart failure and dyspnea. Then kidney failure can lead to acidosis, can cause dyspnea, and also it can cause anemia and cause dyspnea. And so these are some of the mechanisms by so various, so mainly 3 organs, heart, lung, and kidney can cause shortness of breath. In addition, there are other causes like deconditioning. What do you mean by deconditioning is because of prolonged inactivity of individuals, because of their sedentary lifestyle or because of obesity, people, their muscle strength drops. Not only muscle strength, their organ reserves are also reduced because they are functioning at a lesser capacity. So their cardiac reserve, their respiratory reserve, their muscular reserve is less, so that they can't generate, they are not unable to involve in activities which needs a lot of, increasing function of the organs. So they're not used to that. So what happens is when they are sedentary for a long time, if they are going to engage in an activity which needs more oxygen and organ overactivity, they are unable to tolerate it. So then they become fatigued and they become breathless. This is what happens when people who have not been exercising or walking or active, when they suddenly try to do something, they get short of breath, and that is because of deconditioning. So that is also another condition, another cause for the dyspnea. So this is exactly, so these are the broad groups that can cause shortness of breath. Okay, so now moving on to this case. Before that, when one more important concept, that is when you talk about people with shortness of breath, how to categorize according to the acuity of onset. Some people come with acute dyspnea, some people come with chronic exertional dyspnea. So there are different groups of diseases which can give rise to these two groups. For example, somebody coming with acute shortness of breath, you have to think of pulmonary edema, asthma, COPD, pneumothorax, pneumonia, a pulmonary embolism, inhaled foreign body, a collapse of the lung, anaphylaxis giving laryngeal edema, and things like that. Whereas if you are thinking of chronic exertional shortness of breath, you're thinking of more heart failure, angina. So as I told you about angina equivalent, then again COPD and asthma can give rise to chronic exertional dyspnea also. Then things like interstitial lung disease, chronic pulmonary thromboembolism, and large pleural effusions. These are chronic ones. And again, deconditioning, obesity, and severe anemia also give rise to chronic exertional dyspnea. Okay, so having gone through these, then we move on to this patient. Now, this patient came with exertional shortness of breath. Now, you have had some idea as to what are the broad categories of diseases which can give rise to shortness of breath in this patient. So let's go through the symptoms. So the patient says that she's not breathless at rest or night. So this is an important thing to ask. And also she goes on to say she doesn't have orthopnea or paroxysmal dyspnea. So what are we basically checking for here? Absence of orthopnea and paroxysmal nocturnal dyspnea?
Heart failure.
Yeah, heart failure, specifically left ventricular failure. Then no cough, wheeze, pleuritic chest pain. So basically, we are basically covering for any respiratory diseases. So she doesn't have any cough, wheeze, or pleuritic chest pain. She doesn't have angina. So again, angina, I said, dyspnea is an angina equivalent. So sometimes you might not have angina, but the breathlessness is the only feature of coronary ischemia. But anyway, she doesn't have angina, she doesn't have palpitations, claudication, or calf pain. So she doesn't seem to have a vascular, ischemic vascular disease. Then she doesn't have periorbital puffiness or abdominal swelling. Why are we asking this question?
Renal
Yes, that's right. So mainly to exclude any renal disease. No change or color in urine, no nocturia or frequency. So she doesn't have any urinary symptoms to suggest any renal disease, but that doesn't mean that you are not having a renal disease. You can still have it. Her appetite and bowel motions, no change. This is a general question to ask for any systemic diseases. No bleeding, PR or melena. Why are we asking this question?
VLCD.
Not really, because the case is dyspnea. So why do somebody wants to ask about bleeding?
Anemia.
Anemia, that's right. Yeah. And then about skin rash, there are no skin rashes, mucosal ulcers, change in hair, skin or nails. Why are we asking those questions?
Iron deficiency.
Any other thoughts?
Autoimmune.
Exactly. So autoimmune diseases like lupus, they can give rise to lung problems. Autoimmune diseases can be associated with especially interstitial lung diseases. So that is why you ask for these questions. No joint or muscle pain or stiffness, again, same thing, rheumatological disorders. Sleep undisturbed, refreshing, non-snorer. Why are we asking that question?
Obstructive sleep apnea.
That's right. So obstructive sleep apnea, people can also have various problems that can cause, especially you can even have hypoxia, and also can lead to, pulmonary hypertension and things like that. So that is why you have to exclude that. No asthma or rheumatic fever during childhood. Why do we ask those questions? Asthma, of course, obvious, just to exclude the long-term asthma. Rheumatic fever? Why do you ask for rheumatic fever?
The valvular heart disease.
Yes, that's right. To exclude valvular heart, because basically you're trying to exclude cardiac as well as respiratory diseases. No diabetes, hypertension, ischemic heart disease, or non-renal liver or thyroid disease. No tuberculosis, no arthritis, not on any long-term medications. 2 uncomplicated term live pregnancies, first normal delivery and the second lower segment cesarean section. No abortions, no abnormality in the menstrual cycle, not on OCP. Lives a sedentary and contented life. So sedentary lifestyle may be contributing to a shortness of breath, we don't know. Yeah, and not particularly stressful life. So just why do we ask about the psychological status?
To exclude anxiety, depression, and
that's right. Those primary activation of the amygdala causing dyspnea. So whether he has got anxiety, depression, or panic disorder, nothing of that sort. Husband is a school principal. 2 boys, 15 and 10 years, eats well, not a vegetarian. Okay, so basically now you can understand, because you have an idea about the broad groups of causes of dyspnea, why we have to ask these questions. Now moving on to physical examination. So Physical examination, I will not ask you this question, but crucially, you need to specifically look for disease in the cardiovascular system and the respiratory system. So those are the two groups, two broad systems that you have to focus on. So in addition, you might have to know whether she's obese, because as I told you, obesity can lead to deconditioning because you become sedentary and you don't move around. And because of that, so she is obese. She has a BMI of 32. So that is there. So that could be actually contributing to her dyspnea. Her pulse rate is 90 regular. Respiratory rate is 15. This is at rest. So she doesn't seem to have a resting shortness of breath. So that's an important thing. She actually gets short of breath during exertion. Her blood pressure is 140/95. However, her oxygen saturation is 93. What do you think of that? Is it normal, low, acceptable? What do you think? Anybody? Yeah, it is low. So this suggests that even at rest, the patient is not getting adequate oxygenation. Although her respiratory rate is 15, which is not high, she is having rest hypoxia. So that is an important thing you need to notice. Head and neck, no problems, no cyanosis, no pallor. But as she mentioned, she has an ankle swelling, so she has bilateral pitting ankle edema. So that is an important feature that you need to note. Cardiovascular system, JVP is not visible. So that doesn't mean that it's not raised. It's not visible means probably it's difficult to see because she is an obese lady. Apex not palpable, no parasternal heave, cardiac sounds muffled, no third heart sound, no murmurs. And there is some question about a loud second heart sound, but nobody is sure. So how do you interpret these signs, cardiovascular signs? Any thoughts, anybody?
No significant cardiac problem.
Mm-hmm. Can we kind of conclusively say that in this patient? Anybody else? Any other thoughts?
So because she's obese, because of that, all of these signs may be not clearly seen.
Exactly, that's right. Very good. So because she's obese, she has a BMI of 32. You can understand how difficult it's to do a cardiovascular examination, especially in obese female. So that is why you are not getting, these physical signs properly. So just the absence of any cardiovascular sign does not exclude a cardiovascular problem. So that's the important thing you need to remember. So examining the lungs, there is hardly anything, no crepitations, no bronchi, respiratory system is normal. Abdomen is protuberant, difficult to feel, no free fluid, no organomegaly. Again, problems with obesity, making it difficult to examine. Neurological system, no abnormality detected. Yeah, so now let's see. What are the most likely causes for her dyspnea? Or in other words, what's the likely cause? Is it cardiac, pulmonary, obesity? Is it renal, or is it psychological? Now you can make your suggestions based on the history and the examination. So let's see. Let's hear what you have to say. Anybody? What are your thoughts? You can just tell, there are no hard and fast answers. Whatever you think, you can just come out.
So I think obesity may also play a role in her dyspnea. Cardiacs, I would think that even with the obesity, if the S2 was suspected to be loud, I would think that there might be a significant P2 loud component. So maybe pulmonary hypertension may be contributing to it. And you still can't rule out probably other causes just because.
So pulmonary hypertension, can it cause dyspnea?
Yes, sir. Because
so pulmonary hypertension can cause dyspnea, because I told you in my initial slide, you can have stretching of the pulmonary arteries,
Because of obesity and also the sedentary lifestyle, it could be an ischemic heart disease as well without the angina presenting as shortness.
Yeah, you are thinking of angina equivalent. Whether her shortness of breath could be just a manifestation of underlying ischemic heart disease. So that is also possible because she has got obesity, but obviously she's a female, so that makes her less likely to have less risk of ischemic heart disease. She's young, she's 48. And she doesn't have other risk factors. She doesn't have hypertension. She doesn't have diabetes. So only obesity is the only risk factor. So that is against possible ischemic heart disease. And she doesn't have any other vascular disease. She doesn't have peripheral vascular disease. She doesn't have strokes. Her pulses are well palpable. So those are the things that you need to remember. So those are against ischemic heart disease. Any other thoughts? Especially because she has edema. That's another thing you need to not forget. She has bilateral pitting ankle edema. So how can you connect this to her shortness of breath? Anybody? Edema and shortness of breath, what's the immediate thing you think of?
Heart failure.
Heart failure, yes. So heart failure still a possibility because we cannot exactly do a proper cardiovascular system examination. So we'll have to evaluate that possibility also. Any other reasons for having edema with shortness of breath apart from cardiac failure? Think of broad organs that can be involved in causing shortness of breath.
Renal problems,
Yes, very good. Yes, so renal problems. So patient could be having a renal impairment, which can give rise to edema as well as shortness of breath. So renal is also a possibility in this patient. So that is another. So basically, you cannot exclude anything. Even though you couldn't find any particular problem in the examination, still things are possible. What about respiratory diseases? Could that be a possibility? She doesn't have any lung signs. She doesn't have any crepitations, no wheezing, nothing. But could that be a possibility? Anybody? Because she has completely normal respiratory system examination. So what are the lung problems or lung diseases which can lead to dyspnea without any lung signs? Are there any? If so, what are they?
pulmonary embolism.
Pulmonary embolism, excellent. So in pulmonary embolism, you don't get any lung signs, but you can get shortness of breath. Very good. That's number one. Any other causes, lung diseases which can give rise to shortness of breath without any lung signs?
Pulmonary hypertension.
Yes, this just now we discussed. So pulmonary hypertension also we don't. So when you are talking about primary pulmonary hypertension, where There are, so you can get secondary pulmonary hypertension where you can have a lung problem, and because of that lung problem, you can, because of chronic hypoxia, you can get pulmonary hypertension. We are not talking about that. We are talking about primary pulmonary hypertension, where there's no lung problem, lung parenchymal problem, but you can get hypertension as a primary pulmonary hypertension. There also you don't get lung signs. So that is another differential diagnosis for a patient with shortness of breath without any lung signs. Any other DD for the lung? Without any lung signs, you can have a lung problem. Those are the two main ones. But sometimes you can get interstitial lung disease, especially in the early stages. In the later stages, you can get fine in inspiratory crepitations, but in the early stages, you can sometimes have completely normal lungs on auscultation, but still they can have a shortness of breath, especially on exertion. So those are the three main causes. If somebody asks you how can you have a completely normal lung on examination, and whether they can have a lung disease causing shortness of breath, these are the three causes: thromboembolism, pulmonary thromboembolism, primary pulmonary hypertension, and early interstitial lung disease. So those are the possibilities in our mind. So with that, we will move on to investigations. But before that, I will just give you an outline of various lung problems, which can, not in particularly in dispersion, but anybody coming with shortness of breath, how you evaluate for various causes of lung problems or cardiovascular problems, and how do you suspect a particular cause over the other. So these are the common ones you get when somebody comes with shortness of breath: asthma, bronchiectasis, COPD, heart failure, interstitial lung disease, tuberculosis. So those are the common ones. So we have to think of. And so obstructive airway disease is basically chronic obstructive airway disease or asthma. They usually come with cough, sputum production, wheezing, and breathlessness. And also they can have a feeling of chest cold, sema. Kudakka, they come and say they have sema. And especially after a lower respiratory infection, it takes time to resolve. So these people could be having an obstructive airway disease. And you have to suspect breathlessness. If anybody having breathlessness in a smoker, you have to suspect obstructive airway disease. So how do you differentiate whether it's asthma or COPD clinically? So especially if the disease is early onset, especially in childhood, then it's more likely to be asthma. And classically, the shortness of breath or the breathlessness has a variability. That means it varies from day to day and within the day. So this is an important thing that you need to remember when you are thinking of asthma. So because airway, there is a airway hyper responsiveness, and because of that, from time to time, the airway obstruction varies. So this is a classical thing which differentiates it from obstructive airway disease, chronic obstructive airway disease. So the symptoms or the feeling of shortness of breath, wheezing, changes from day to day. Some days you don't have any symptoms, some days you have wheezing and shortness of breath. And similarly, there are within the day also there can be variabilities. In the daytime you might not get shortness of breath, but in the night time you can have shortness of breath. So this is because of airway hypersensitive responsiveness. So that's a feature of asthma. And also history of atopy, allergic history, is also in favor of asthma. In comparison, chronic obstructive pulmonary disease, it occurs later in life. And usually they have a history of smoking or exposure to fumes. And symptoms are not intermittent. It's a progressive disease where you don't get, if somebody has chronic obstructive pulmonary, it's generally they have the symptoms all the time. And there are no days that they don't have any symptoms and days they have severe symptoms. It's like a progressive thing, persistent thing. And day-to-day variability and within the day variability is less compared to asthma. And the other thing is response to bronchodilator therapy is less dramatic compared to asthma, where the response to bronchodilator therapy is more profound. How about bronchiectasis? There's a prominent cough and sputum production, which is copious and sometimes mucopurulent, and the patient can have also hemoptysis, and you can have fibrosis in the lung associated with bronchiectasis. Then heart failure, you know about the heart failure, how do you present? So patient could be having valvular heart disease, and they can have history of ischemic heart disease, especially risk factors such as smoking, and they can have breathlessness associated with swelling of the feet, and they also can have orthopnea or paroxysmal nocturnal dyspnea. And also you specifically ask if you think of heart disease, any past history of myocardial infarctions, angina, rheumatic heart disease, or presence of other risk factors like hypertension or diabetes. So these are some of the things that are in favor of somebody having heart failure. So we discussed these. Interstitial lung disease. So now there's another group of causes which can give rise to shortness of breath. It can be idiopathic, but can occur due to secondary causes like exposure to occupational hazards like asbestos, can be associated with connective tissue diseases or medications. Can you give some examples of medications causing interstitial lung disease?
Nidoron, nitrofurantoin.
Yes, those are two common drugs. Then usually they have a dry cough, no sputum production, and no wheezing, no hemoptysis. And they have again progressive shortness of breath. TB should be clinical. Again, they have cough. Usually, anybody with a long-standing cough, you have to think of TB in our country. And TB can cause shortness of breath with active disease as well as due to post-primary TB leading to fibrosis. So sometimes the active disease might not be there, but because of residual fibrosis, they can have shortness of breath. And you have to ask about hemoptysis, past history of TB, contact history of TB, fever, weight loss. These are some other things that can be associated with TB. And renal disease. If somebody has risk factors for renal disease, such as diabetes or hypertension, which can be associated with chronic kidney disease, and especially they complain of any urinary problems like reduced urine output, hematuria, frothy urine, and especially if they have edema, periorbital ankle, and other uremic symptoms, especially loss of appetite, nausea, vomiting, pruritus, which might suggest this patient has gone into end-stage renal disease. So these are some of the things which might lead you to think of renal disease causing shortness of breath. So these are some of the symptoms and signs that might be useful into suspecting a particular group of disease. So in this particular patient, there is no evidence of anemia, no pulmonary edema, no valvular signs of valvular disease, no features of obstructive airway disease, no features of lung fibrosis, no features of pleural disease, no features of renal failure, except edema. Right, so we haven't got much clues, but as we discussed, there are few differential diagnoses we have to strongly consider, even in the absence of any lung signs. Okay, so what investigations would you request at this point? So fire off. Yeah, tell me. Few investigations.
Full blood count to see hemoglobin.
Yes, full blood count to see hemoglobin. Any other tests?
ECG to see if there is cardiac involvement.
Sorry?
ECGs.
ECG, yes. Give a list of investigations and the reason.
Serum creatinine and renal function test to see if there's
Yes, renal impairment, yes. There are lots of tests that you can do.
Chest X-ray.
Yes, chest X-ray. So even in the absence of, I said, lung signs, you can have respiratory diseases. So you have to do a chest X-ray. Any other test?
Echocardiogram.
Echocardiogram, yes. Any other investigations? Yeah, so these are the investigations that they have done. Full blood count is normal. ESR, serum creatinine, serum electrolytes, liver function, urine full report, sugar level, they are all normal. So basically now we can safely exclude renal disease, right? Hemoglobin is 11.5. The patient is not profoundly anemic to cause anemic enough to cause shortness of breath. So that is also unlikely. So then we have done the ECG and the chest X-ray. Let's have a look. So this is the ECG. Just have a look at the ECG and tell me what are the problems and what is the diagnosis.
So in V1 and V2, there are deeply inverted T waves suggesting like a Whelan's pattern.
Sorry, what pattern?
Whelan pattern.
What is that? I don't know what that piece means. Well, what does it indicate? T inversions in V1, V2, only T inversions.
ST depression.
So what does this indicate? Anybody?
Ischemic myocardium due to stenosis of the coronary arteries.
Ischemic heart disease. So yeah, possible. So that might is in favor of any kind of like whether she has a kind of underlying ischemic heart disease. Okay. Any other thoughts? Any other abnormalities you noted in this patient? What about leads 1 and 2? Are they normal? Where is the cardiac axis? Is it normal or deviated?
Right axis deviation.
Why do you say right axis deviation? Because usually you would expect the left leads, lead 1 and 2, to have upward R wave. And here actually the lead 1, you get a predominantly a S wave, a negative R wave. And even the R wave progression, if you look at it, even in lead V6, the R waves, are not totally upright. So that's why, you are right. So there is a right axis deviation. So why is he having right try why is she having right axis deviation. Probably there is some problem causing right ventricular hypertrophy. So this is a right ventricular strain pattern. This is not due to ischemic heart disease. So this axis has moved to the right because the patient has got a right ventricular strain pattern. So that is what you see in this ECG, right? And this is the chest X-ray. So again, you see the right axis deviation. So the negative, prominent S waves in lead lead one, and sometimes you can have even a right bunch block pattern. And as I told you that even these are different patients ECG, you can have a different poor RV progression. Right. So this is the X-ray. So this is the is there any evidence of lung disease, parenchymal lung disease in this patient? There doesn't seem to be anything abnormal. There doesn't seem to be anything abnormal, right? Well, I would just normal X-ray, right? Doesn't be striking. Right ventricle is dilated. Tricuspid regurgitation is there. Left not dilated. No mitral valve abnormality. No septal defects. So what is the problem now? Is the
Pulmonary hypertension.
abnormality? What is abnormality? Raised pulmonary arterial pressure. So this patient has, you might go back when you look at it again. I don't think you can end up. So the next question is whether this is a primary pulmonary hypertension. No. So what do you do now? How do you move forward? Any thoughts? We are somewhere there now. Earlier we didn't know what was happening. Then now we have a clue. We have got a patient now. Now what is the next? Anybody? If somebody has pulmonary hypertension, what is the next step? What do you want to know now? What is the next question? Can we stop there? Diagnosis. We discussed about this short while ago. Anybody? What do you need? Anybody? What do you need to know to manage?
So whether this is a primary or secondary, sir?
Why Hello, can you all hear me?
Yes,
Yes.
sir.
Yeah, I
Can-
think I got disconnected. I had a problem with my connection. So did you all hear what I was telling last bit?
No, sir. We
From the
couldn't
echo
hear.
side, sir, your line was breaking up, sir.
Okay, no, we'll go back. I'll just share the slides. Yeah. So so we discussed about the echo findings. So what is the diagnosis? We discussed about the diagnosis, right? Pulmonary hypertension. Can you hear me now?
Yes, sir. Can hear you.
Yeah. So basically, this patient has got pulmonary hypertension. What is the next question?
The cause of the primary hypertension, whether it's primary or secondary?
That's right. So the next question is whether it's primary or secondary. So what do you want to do now? What are the next steps? What are the things you would want to do now?
Measure the pulmonary pressure with right heart catheterization.
Yeah, no, that will tell you that there's pulmonary hypertension now. So pulmonary artery catheterization will confirm that there's pulmonary hypertension. But will it tell you whether it's a primary or secondary? What are the other tests that you would want to do to find out whether this is a secondary pulmonary hypertension? So think of the possible causes, considering the fact that the patient has got no lung signs. Also, what are the differential diagnoses and what are the things that you would want to check for? What are the possible underlying lung problems still which could be causing this patient's pulmonary hypertension?
Primary embolism?
Sorry?
Primary embolism?
Yeah, pulmonary embolism. So pulmonary embolism, this can't be acute pulmonary embolism because, you know, their presentation is different. Where you suddenly come with a shortness of breath, previously normal person suddenly coming with acute onset shortness of breath. This is not that. No? So this is where patient comes with a progressive shortness of breath for 2 to 3 weeks. It's a subacute presentation. So what should be the type of embolism in that situation? It is a chronic pulmonary thromboembolism, recurrent. So you might be having little emboli shooting from time to time, and now this patient has developed pulmonary hypertension. So you don't get pulmonary hypertension with one acute pulmonary embolism. You will have multiple pulmonary embolism now blocking the pulmonary arterial tree, and therefore they get hypertension. So, so how would you investigate for that?
CTPA, sir?
Yes. So that is the next step. CTPA. Any other test you would want to do?
So would D-dimer levels help?
D-dimer levels, yes. Other tests? What are the other tests that will be useful in evaluating somebody with suspected pulmonary embolism? D-dimer is correct. CTPA is correct. Any other test? Especially when somebody has a normal looking lung on the X-ray. Have you heard of ventilation perfusion scan, VQ scan? So that's another test that you would do. Other thing I told you was interstitial lung disease. You can have early interstitial lung disease without any lung signs. So what's the test that you would do?
HRCTs?
Yeah, high resolution CT. So let's see how those look. And another test that you want to do is a spirometry. So that might also give you some idea as to what the lung functions are. So before that, I will just give you an outline about pulmonary hypertension. So pulmonary hypertension can be due to primary pulmonary hypertension or due to secondary causes. So these are some of the secondary causes. You can have shunts, cardiac shunts, collagen vascular disease, and various lung problems, and chronic thromboembolism. So this is the spirometry of this particular patient. So you have, so this is the patient's one, right? Which is normal. Where in a restrictive lung, where you have, if somebody has interstitial lung disease, you have a reduced FVC, forced vital capacity. So this patient's lung capacity seems to be normal. So that is against interstitial lung disease. This is the high resolution CT, and this is not the patient's one. Actually, patient's one is this. So the patient's one is actually normal. This is a patient with interstitial lung disease. So there is no honeycombing or any ground glass appearance here. So there is no evidence of interstitial lung disease. So that seems to be out. So any evidence of thromboembolism, these are some of the things you would want to do. We have spoken about D-dimer, VQ scan, CT pulmonary angiogram. Also, you can do a Doppler of the lower limbs just to exclude a DVT. So this is the ventilation perfusion scan. So this is the ventilation scan, and this is the perfusion scan. What is the abnormality?
Right lung is poorly perfused.
Not poorly perfused. Actually, it's not perfused at all. I mean, I can hardly see any markings on the right lung. So there seems to be some blockage of perfusion in the right lung. And there's another ventilation perfusion scan. So you see this is the ventilation scan and this is the perfusion scan. You see there's a clear defect in the right perfusion. These are two different patients VQ scans. So what you have, this is how you see it. So that if you get a patient with pulmonary embolism. So ventilation is normal, perfusion, there are defects. And this is the CTPA. So here you see that these are the main pulmonary artery, right and left, and you see there's a clot here, right? So this is what you see. This is not from the same patient. This is a different slide, different photograph. So this patient has got chronic pulmonary thromboembolism causing pulmonary hypertension. So that is the diagnosis. And why this patient has got bilateral leg edema is because of right heart failure secondary to pulmonary hypertension. This is called, what do you call that?
Copulmonalis.
Copulmonary. Yeah, that's the diagnosis. Okay. So are we done or do we need some more things to do? Now, management part, I'm not going to discuss. I'm still on the diagnosis side. So are we happy with the diagnosis or do we still need some more?
So we still need to know what causes pulmonary embolism.
Excellent. So what are the things you would want to do? Why should somebody develop pulmonary embolism? Any thoughts, any possibilities for this particular patient? What are the things you would want to check?
Does she have a hypercoagulability state?
Yes, whether she has a hypercoagulability state. So what give some examples of hypercoagulable states that people can have?
So polycythemia rubra vera.
Can she be having polycythemia rubra vera?
The full blood count was normal.
Normal, so it's unlikely. Any other?
OCP use?
OCP use. She's using OCP, right? I can't remember exactly. I think she was using OCP. So that's a risk factor for thromboembolism. Any other conditions?
Malignancy causing hypercoagulable state?
Could she be having a malignancy? If so, where? Because we have screened her lungs, so the unlikely to have a lung malignancy. Whether she is having a breast malignancy, ovarian malignancy, colonic, pancreatic, those are possible. Yes, agreed. But she's too young, no? She's 48 years. So malignancy doesn't seem, we can get malignancies at that age, but that seems less likely. Any other conditions which can give rise to hypercoagulability?
Protein CS deficiency.
Yes, yeah. Protein CS deficiencies, yeah. And antithrombin 3 deficiencies, yes. So you might have to check for those. Any other hypercoagulable states, you know? Common in females?
APLS.
APLS, yes. APLS means antiphospholipid syndrome. Yeah, so that's another thing you might have to check for lupus anticoagulants and anticardiolipin antibodies, right? So those are the things that you might want to check here. And also you might want to do an ANA just to exclude the, underlying connective tissue disorders which might give rise to APLS also. Yeah, so this is, so that's the entire thing, so this case, so we started with shortness of breath or dyspnea, and then we gradually worked up how the case, and then we came to the differential diagnosis and excluded some of the causes, and then we gradually, based on the investigations, come to this diagnosis. So this is how you kind of work up a case of dyspnea, and it has to be a stepwise approach. And the next case will be totally different, but if you do the assessment in a very sequential and a organized and a proper way, you will get to the right diagnosis. So are there any questions? We'll stop there. So if you have any questions, you can ask.
So one question, sir. So with regards to that initial slide, so that you showed about the major mechanisms of dyspnea, so one of the things that was there was that increased aorta pressure baroreceptors can also cause dyspnea. So can systemic hypertension itself cause shortness of breath?
It doesn't. Systemic hypertension doesn't cause, but basically, aortic pressure means, these are just aortic root kind of pressures, not in the systemic vasculation. Probably what they are talking about is things like aortic stenosis and, things like root dilatations and, those things maybe can give rise to a shortness of breath. But I don't think the smaller vessels, stretch can cause any feeling of shortness of breath. It's mainly related to the big vessels, right?
Okay, thank you.
Yeah. But hypertension can cause shortness of breath if it's very high, and you can guess hypertensive heart failure, where the hypertension gives rise to cardiovascular strain, because the left ventricle has to push blood against very high blood pressure. So therefore the left ventricle gets strained and you get stretched because they're trying to pump forcefully the blood from the left ventricle. And because of that, you can get left ventricular failure, and that can give rise to dyspnea. Same with aortic stenosis. So if somebody has got aortic stenosis also, one of the clinical features is they get exertional shortness of breath and exertional angina. That's because of that extra force that the heart has to generate to pump blood against the obstructed outflow tract. So same thing can happen with hypertension. So when you have very severe hypertension, when the heart tries to pump against that blood pressure, you can have exertional shortness of breath. but it has to be very high pressures, not mild pressures, right?
Yes, sir. Thank you, sir.
Any other questions? There was a question sent on the chat. To consider positive contact history, how long should the person be exposed to a patient? I don't know the answer to that question. Basically, to be a positive contact history, how long should the person be exposed to a patient with TB? Well, contact history of TB is a very vague thing. I don't know. I mean, in our context, I mean, any of us can be contact with TB because it's so common and in the community. So I don't know. I don't know how you were taught, but I don't know the answer for that question. Any other questions?
That poorly perfused area, is it already infarcted or?
Could be an infarction, but sometimes it may not be infarcted. It just may be poorly perfused, but there is some viability there. So maybe infarcted, may not be infarcted. So it may not be totally necrosed. But if it's a chronic process, it's likely to be infarcted because it's now some time back, no? So yeah.
Thank you, sir.
Okay, so we'll stop there then. So unfortunately, there are only 16 of you there, 16 including me, that is. So about 15 are there. So, but I hope you learned something from this lecture. And if anybody wants, I can share the slides with you all. But I don't think you can learn much from the slides because it's mainly the discussion that was kind of useful to understand how to assess a patient and manage a patient with dyspnea. So yeah, so if you want, I can send you the slides and you can share with the others, right? Okay, then we'll stop there, right?
Thank you.
Thank you, sir.
Thank you,
Okay.
sir.
Thank you.